Hello, this is Dr. Junsuk Bae of Cheongdam Wooridul Spine Hospital. Today, I would like to talk about ossification of the posterior longitudinal ligament. OPLL is also called ligament ossification disease, and the ligament in question is called the posterior longitudinal ligament. As you can see, the spine here, the front of the spine faces the abdomen, and the back faces the backside of the body. The one that supports the front is called the anterior longitudinal ligament. There is a posterior longitudinal ligament on the back side of the vertebral body, ligamentum flavum, which mainly causes spinal stenosis, and many other ligaments. The reason why the posterior longitudinal ligament we are discussing today becomes a problem is because it is in direct contact with these yellow-colored nerves. Since it compresses the nerve from the front, treatments become a bit more complicated. OPLL is a spinal disease in which calcium deposits accumulate in the longitudinal ligament in the back, making it as hard as bone. When approached from the back, as in most typical spinal surgeries, this posterior longitudinal ligament is not directly accessible by the nerves. So even if it's pressing on the nerves, it's impossible to see it from the back. And to see it, you'd have to pull the nerve sideways. Doing so can cause nerve damage immediately. Therefore, this surgical approach and treatment method have many variations and require high levels of skill. Thoracic OPLL is particularly difficult because the heart and lungs are at the very front of the thoracic spine. To the side, there's the aorta, and a bit further up, the esophagus covers the area. And there is a trachea in front of that. Since critical organs that should not be touched surround this spine, and OPLL is hidden in the very center, treatment becomes extremely complex. Another concern is that most of the patients who have this spinal disease get diagnosed late. Early symptoms of this include feeling unsteady when walking. They start to mildly recognize the symptoms, such as having anemia. Once the disease progresses significantly and is finally diagnosed, nerve damage has already advanced quite a bit. There are 12 thoracic spines, and OPLL often appears in multiple segments. At least 2 or 3 segments are compressing the nerves in multiple areas and are diagnosed late. It is similar to pancreatic cancer, which is a well-known abdominal cancer. It's diagnosed late, lies deep inside, and is very difficult to treat. OPLL in the spine is a similar case. The most important thing is early detection, and any issues can be detected through an MRI. If appropriate medical attention isn't received at the right time, by the time a patient visits the hospital, the condition may have progressed considerably. Symptoms like constipation, delayed urination, or a feeling of residual urine, pulling or pain in the legs, abnormal gait, tingling in the soles of the feet, dulled sensation in the soles, frequent stumbling on stairs, or any walking issues should prompt a full spinal check to check for OPLL. When treating nerve compression-related lesions, the most important thing is to avoid damaging the nerves. Especially in the thoracic spine, the approach comes completely from the side. If the spine is here, the approach goes from the side, removing only the ossified portion that's pressing on the nerves from the front, without touching the nerves. For this surgery, it's essential to operate together with an experienced thoracic surgeon. Avoiding the heart and lungs, the ossified bone is removed under a microscope using this surgical technique. The most challenging part of the surgery is when the ossified bone fragment penetrates the nerve. The membrane surrounding the nerve is called the dura mater, and if the bone tears part of that and invades the nerve space, the surgical difficulty increases significantly. Among the surgeries we can imagine, this is one of the most challenging, especially since about 70% of OPLL patients undergo surgery with some degree of dural damage already present. Because of this, the surgery takes a long time, and the hospitalization and rehabilitation period afterward is also relatively long. In the past, this surgery required removing 1 or 2 ribs. To operate on one segment, 1 rib was removed. For 2 or 3 segments, 2 or 3 ribs were removed. The resulting pain after surgery was intense. But since this surgery was unavoidable, patients had to endure the pain during treatment. The surgical method we developed doesn't involve removing ribs. Instead, a very minimal incision is made, and the OPLL compressing the nerve is removed through a narrow space between the bones. This method, which uses an approach through the armpit, involves making a small incision in the armpit, slightly spreading the ribs in the deep space between them, and removing the OPLL even through that narrower space. This is very beneficial for patients, although very difficult and exhausting for surgeons. But the reward is that we were able to treat many patients who previously couldn't be treated. Patients who couldn't walk, who used wheelchairs or crutches, were able to walk well after surgery. That result gives us great satisfaction. Most of the patients who visit to see me told me the same thing, that their previous doctors or hospitals told them surgery is impossible, or the success rate is not high, and they gave up on treatment. But then, as the pain became unbearable, they came to us suffering. So even if you have OPLL, you should not give up on treatment. It's indeed difficult to treat, but the term impossible is a completely different matter. Don't be too discouraged by one hospital's statement that surgery is not possible. Be sure to visit Wooridul Spine Hospital and receive proper treatment.